Good afternoon, everyone. I know it's not the right time. Everyone is hungry, and I am the only obstacle in between you and your plate. But you can sit with your plates, and we can have interactive session. In just 10 minutes, I will complete it, and we can discuss. So, what is myth versus fact in ICU? Since 2 years, I was planning to write a chapter on this topic. But unfortunately, due to some time constraint or some other commitments, I could not even initiate it. But due to this Guj Criticon, this came in my mind, and rather than a chapter, let me first start with the presentation, and then I can start writing a chapter on this. So, for me, myth in ICU is what was the fact I felt when I was doing MD. And the actual fact which I learned during my critical care training is the actual fact. So I will discuss that, what during MD we feel which is fact, which is actually a myth, and what is the actual fact. So I will not discuss each myth in detail. I will just show my take-home message, and then I will leave tasks on the chairperson and panelist. So without going in detail for each slide. So myth is low CVP give fluid, low IVC give fluid, so it's myth. We have to correlate it clinically with other parameters. Myth for oliguria, we have to give diuretic, we have to give Lasix. So it's not always like that. It's not recommended as well. Only with fluid overload and oliguria, diuretic challenge is recommended. Myth is tachycardia, so we have to give fluid bolus or start ivabradine tablets. It's not like that. We have to find the etiology and treat etiology of tachycardia before treating with ivabradine or fluid bolus. So myth, give Hemasil bolus during large volume resuscitation, so it's not recommended. For details, I will leave it on panelist. Except albumin, no colloid is recommended for bolus. And another myth, give dopamine for renal dose. So dopamine renal dose is also not beneficial and it's harmful. So we have 3 nephrologists on dais, they will discuss on that. Another myth, during our MD days, we can see in each city hall in intubated patient, we used to write metronidazole. We are giving cefosulbactam, we are giving piptaz, we are giving meropenem, and along with that, we are adding metronidazole. So is it really required? Our panelist will give answer to that. Another myth, do not give RL as patient is having high lactate and patient is having hyperkalemia. Is it so? No, it's not like that. So our panelist will discover that fact. Another myth which routinely old ICUs follow, that clamp the Foley's catheter before removal. Is it really required? So that answer also we will get from panelist. Another myth, whether we have to use bowel sound as an indicator to start feed. So it's not actually, we don't check only bowel sound, we use other parameters as well. So we will discuss that. Another myth, if we can give feed if patient is on vasopressor, yes, we can give with low dose. With high dose, we have to assess for tolerance. Another myth, we usually intend to stop feeding in intubated and tracheostomized patient who are having Ryle's tube. So is it justified? We are interrupting so many calorie and protein during interruption of transport for CT scan, for contrast, or any other procedure. So NBM is required for such kind of patient? It's not. So we have to educate our junior colleagues, nursing staff, and physicians. And just last thing, normal BP mean patient is okay, fine. No, it's not like that. Shock can be there. Cryptic shock can be there with normal blood pressure as well. So we have to check extremities, pulse volume, urine output, and other parameters. So I will just leave first on our 3 panelists to elaborate each of these myths themselves, and our nephrologist colleagues and our senior esteemed physician will give take-home message. On you, sir.
Majority of fact, which was a fact in past, now myth, is because of good echocardiography in ICU and POCUS. Initially, so after POCUS and good echocardiography in ICU, many things in the past was fact, now it is myth. I would like to comment on this dopamine renal protection. I think nowadays nobody is using, majorities are knowing that it is a myth. What was the theory that dopamine in low dose act on selective D1 receptor and cause vasodilatation, increase renal perfusion. But in critical ill patient, now study shows that this selectivity, the critical ill patient lost. So it is not that dopamine in low dose act only on D1 receptor. And furthermore, if it increases the renal perfusion, but it doesn't increase the filtration. So perfusion is not equal to filtration. So there is no advantage in increasing urine output or preventing AKI or reduce incidence of RRT. So now nobody is using dopamine in kidney protection. There are many other ways to protect the kidney in critical ill patient. Regarding clamp of catheter before removal, also now it is very clear for short-term duration. Few patients require clamping, very few patients. Particularly those who have very long-standing catheter, more than 3-4 weeks, neurogenic bladder or very mega bladder, they require bladder training. But majority of the patient in short term, less than 3 weeks, there is no advantage. There is no reduction in the incidence of recatheterization. On the contrary, sometimes it increases the chance of urinary infection.
Exactly.
So majority of the patients.
I want to highlight, so many are thinking after giving RL in cases of hyperkalemia, acidosis, it worsens the hyperkalemia. But it 4 milliequivalent per liter potassium level is there in RL, and also lactate will be converted into bicarbonate. So in cases of metabolic acidosis, sepsis, septic shock, RL will be fruitful to maintain the pH, and as well as also it also decrease the potassium level when in cases of hyperkalemia. So RL should be given. One contraindication is there only if a patient having a acute liver failure. So liver will not convert that lactate to bicarbonate. At that time, we have to think about not giving RL. Otherwise, RL is a good resuscitation fluid, and it's best in these scenarios. And almost all things are covered. One take message: we should always think about the diagnosis also. Directly jump onto the antibiotics. When patient came with shock, hypotension, poor perfusion, everybody is thinking about giving higher antibiotics like meropenem, and with meropenem, they used to think meropenem will cover gram-negative and gram-negative and all other organisms, and we have to add another antibiotic like teicoplanin and vancomycin. But it's a myth. First, we have to optimize our diagnosis before starting any antibiotics. Yeah, in critical scenario, in emergency, we have to give, but just we can start with BLBLI or carbapenem only. And another, I want to add one myth in Sir's portfolio, like kept patient NBM before procedure. How many hours we have to kept person NBM to prevent the aspiration? The logic behind surgeon kept person NBM to prevent the gastric aspiration. So someone says 6 hours, someone says 8 hours, someone says 12 hours. But without water, 12 hours is very difficult. So
basically for liquid, it's 2 to 4 hours.
Yeah.
But here, when airway is secured in ICU, patient is intubated and tracheostomy, is why we are worrying for aspiration. So it's a myth.
Yeah.
Any patient with secured airway, we don't need to stop their feed.
No, that's not a secured airway. That's routine practice, routine bed surgical patients, elective surgical patients. surgeons are kept patient NBM for 12 hours, sometimes 14 hours, sometimes procedures get delayed till 16 hours also. Some patients are NBM only. તો પાણી પીધું છે કે નહીં આજ પૂછવામાં આવે.
Dr. Danish. And I just would like to add one thing. So in RL, for hypokalemia, we need to give at least 200 MEq to raise the potassium level by 1. And ringer lactate contains, as Dr. Nirav rightly said, just 4 MEq per liter. So even if we give 2 liter, 3 liter, how much it will increase? So it will not actually increase acidosis, and it will help. So Dr. Danish,
We
you
have
can.
to take multiple readings with resuscitation. We can use other parameters like if a patient is arterial line, then we can use leg raising test or pulse pressure variation we can count. We can also use POCUS for same IVC with B lines, and we can count cardiac output by LVOT VTI. So only IVC or CVP as a single reading we should not use. Second thing on oliguria, without overload, yes, we should not use, because Lasix, even if patient is hypovolemic or hypovolemic, Lasix will worsen the kidney. So we should not use Lasix if patient is hypovolemic. So we have to find out whether there is fluid overload or not. Third part is tachycardia. Should we give bolus directly without knowing the fluid status, and should we use ivabradine? So we can, if we don't know the etiology, it can worsen the condition of the patient if we don't know the, if we just decrease the heart rate. So we should not use regularly.
We always, I always emphasize every consultant and physician, whenever we see the patient, we have to, with vitals, and we have to examine patient fully, because concept of tissue perfusion is also important. Cold extremity, sometimes patient having a normal blood pressure with shock. So we have to also think about checking the vitals with proper examination of every system, and we have to touch the patient before.
This is very common scenario in ICU. We got call, sir બધું બરાબર છે, બીપી એકદમ નોર્મલ છે, અને 2 કલાકમાં ફોન આવે, શ્વાસ ચડી ગયો, 6.8 pH, 10 લેક્ટેટ, અને હવે હાઇપોટેન્શન છે, આર્ટરીલાઇન નાખે તો ટ્રિપલ વેસો પ્રેશર 2 કલાકમાં ચાલુ થઈ જાય. So it is clients resuscitated well, and we could have prevented it.
So very few indication. One is that fluid overload. If you don't want to dilute your patient and you want to get rid of extra fluid, that is one indication. Secondly, is very specific settings like pigment nephropathy, patient having rhabdomyolysis, severe hemolysis, and we want to maintain urine output of at least 0.5 ml per kg per hour. So that is a very few indications. One line regarding the use of dopamine, as said, majority of the studies shows there is no benefit of dopamine, and few studies have showed it's harmful. It's more of arrhythmogenic. And third sentence regarding the Foley's clamping, again, it put the risk more chances of pyelonephritis, UTI, and it's better to take a chance of reinsertion of Foley's rather than to clamp.
Thanks for sparing your time and keeping your stomach hungry. So I would
Thank
like to conclude my talk. If anyone come across any additional myth, please share it to my email address or WhatsApp, and I will add to my list, and I would like to start writing chapter on same. Thank you.
Thank you, Dr. Vitrag Shah, sir. Thank you, Dr. Kalpesh Joshi, sir.